Assalamu alaikum. This is Shama Tuzara. So sorry for the inconvenience. It was a technical issue because of which the video get disconnected. So it's the second part of my discussion on diagnosis of acute interstitial nephritis and the treatment of acute interstitial nephritis. So we were on urine analysis, that how we will identify a patient of acute interstitial nephritis through urine analysis. It was a sixth modality that we were discussing for diagnosis purpose. So yes, what you will see in it, white blood cells will be elevated and patient will have increased levels of eosinophils in the urea, except in which conditions? NSAIDs induced acute interstitial nephritis, in which there will be no eosinophil in urea seen, except otherwise it will be present. Now another important finding is that urine may contain microscopic hematuria. Means hematuria is basically that you will find microscopic blood in the urine. Okay, second is proteinuria, that you will see some proteins in the urine. Now I'll just discuss a bit of this concept of proteinuria, why proteinuria occurs. So basically, first of all, this proteinuria occurred because that our some of the cytokines are released by the inflammatory cells within the interstitium, and these cytokines are basically permeability increasing factor. So proteinuria, why? First important point that we should know why this proteinuria occurred. This proteinuria basically occur because the inflammatory cells which are present within the interstitium of the kidney, they will release, as we have discussed before, that their work is to release inflammatory mediators. So they will release cytokines which are like permeability increasing factor. So these are some permeability increasing factors that release, which increase the permeability of the filtration barrier. We call it glomerular filtration barrier. That barrier permeability is increased, and as a result what happens, proteins start to lose within the urine. Plus another cause is of course that damage is occurring, so it will cause proteinuria, protein loss. So moving on here, that which sort of protein loss will occur. First of all, that this proteinuria, mostly it's mild proteinuria, that is less than 100 milligram per millimole. So it's less than that, fine, in most diseases. But very important point, that if patient is having NSAID induced acute interstitial nephritis, then what will happen in that case, that patient will present with massive proteinuria. It's a very important point for MCQ purpose and for your clinical practice, that massive proteinuria will be seen. And what will be the range of this proteinuria? It will be of nephrotic syndrome range. And as we know, how you can remember that why there is proteinuria in nephrotic syndrome, remember this O and protein O, PRO. So it will have proteinuria, and its range will be greater than 3.5, as I repeat, gram per deciliter. It's not milligram. So it's a very high amount of proteinuria. Now this proteinuria will develop, and of course with this protein albumin will be lost, so albuminuria will be present, and if this occurs, then patient will have edema in the whole body. Fine. So this is the main discussion which I have to tell you about the proteinuria. I think this was important, you should know it. Moving on to another important point, that if we perform urine sedimentation, or the urine sediment is performed on this urine, then what we'll see is that we'll see WBC casts in the urine. Very important point, that we'll see WBC casts in the urine. This is also investigation. And the last modality, or you can say the definitive diagnosis modality, is that our last point, that if someone asks you that what is the investigation done for definitive diagnosis of the acute interstitial nephritis, then you'll say that we'll perform renal biopsy. It's very important. I'll write here in front of it that it is the test that is performed for definitive diagnosis. I repeat, it's very important. It is for definitive diagnosis of acute interstitial nephritis. Now, what you will see in the renal biopsy, it's not very common. I've explained you the whole pathophysiology. I'll expect that this will already be in your mind, that inflammation, yes, inflammation will be seen in the patient. So what we'll see in the renal biopsy, we see intense inflammation seen in the kidneys, plus there will be infiltration of what? Of course, the white blood cells. So polymorphonuclear leukocytes plus the lymphocytes will be present there. Now, another important point, that if the patient is having, I'll write here with another pen, that if the patient is having drug induced acute interstitial nephritis, or I have told you in the causes video that collagen vascular disease or sarcoidosis can also cause acute interstitial nephritis. So if these two diseases are present, then in that case we'll see granulomas in the biopsy too. Fine. And another important point, that we can't differentiate between acute interstitial nephritis and, I'll write it here, that acute interstitial nephritis can be differentiated from acute tubular necrosis only by the renal biopsy. So we can't differentiate these two diseases by the clinical investigations or on the clinical grounds. So we require renal biopsy for it. And another important point, that mostly we don't perform renal biopsy. Why? Because of its invasiveness. It's of course an invasive procedure, so we perform less. Mostly the disease is identified or it's diagnosed by the other modalities which I've discussed before. So this is all about how we will diagnose a patient of acute interstitial nephritis. Now moving on to our last part of discussion today, that how we will manage a patient of acute interstitial nephritis. Now it's very easy. First of all, of course, we know that it's because of some drugs, some offending agents, some toxins or infection. So whatever the underlying cause is present, we will first of all remove that cause. So talking about the treatment, our first point that will be of treatment is that first of all we will remove the offending agent. So if it's NSAIDs or if it's all the PWS causes, or in drugs I've explained you P's drugs. Fine. So all the offending agents, we will remove that. Now if we have removed the offending agents, in most cases the disease will be reversible and the patient will recover. Fine. But if we have removed the offending agent, but still we will continue to perform our RFTs now. So if the creatinine levels are still high, then what we will do is that we have an option of giving steroids, because now we have to treat the disease, so we will give steroids in that case. So first of all, what we have done, we have removed the offending agent. If it doesn't work, then we'll go for steroids. Now how will these steroids work? That we will use prednisolone. Its dose is 1 milligram per kg per day. Now, what is the benefit of these steroids? That it will perform two very important tasks for us. That first of all, it will contribute to the rapid recovery from the disease. First of all, and secondly, it reduces, I repeat, it reduces the incidence of scarring, fibrosis. So this is reduced, and what does it does by reducing it, that the damage will not convert into chronic interstitial nephritis or into irreversible damage. It won't convert into that. So it's our steroids we use, and steroids, mostly the disease is responding to steroids if it's not responding to removal of the offending agent. So the third modality, which third step of treatment is that we will treat the, as we know that if one of its cause is infection, so we will treat infection if it's present. So yes, these are very simple treatment of the acute interstitial nephritis. First is we remove the offending agent. Just a quick summary: we remove the offending agent. If the creatinine, mostly patient will recover and the disease will be reversible in that state. But if we have removed it and creatinine levels are still elevated, then we'll go for steroids. We use prednisolone 1 milligram per kg body weight per day, and it will cause rapid recovery, decrease incidence of scarring and fibrosis. And last, we will treat the patient with infection, treat the infection if it's present in the patient. This is all about the management of acute interstitial nephritis. I hope it helped you out. I hope it cleared your concepts. At the end, thank you very much for supporting, and please like, share and subscribe and continue supporting me. Thanks a lot. Allah Hafiz. See you in the next video.